I'd like to thank the organisers of BDER 2022 for the invitation to give a talk today. My name is Professor Steve Bain. I'm based in Swansea University in Wales in the UK, and I'd like to give some thoughts on the Year in Diabetes 2021. Just to show you, this is the School of Medicine in Swansea University, a very beautiful bay on the southwest coast of Wales. So these are my disclosures. So the Year in Diabetes 2021, obviously the major dominant feature was COVID-19, but I see that you have a talk on COVID-19 and diabetes immediately after this presentation, and so I'm going to leave COVID for others to discuss. So the areas that I'm going to talk around are SGLT2 inhibitors or sodium glucose transporter 2 inhibitors, glucagon-like peptide 1 receptor agonists, a little bit about dual agonists, and then finally finish off with a couple of slides about insulin. So to begin with the sodium glucose transporter 2 inhibitors, in 2015 we had the report of the EMPA-REG outcome trial, which was the first cardiovascular outcome trial in type 2 diabetes to show superiority in terms of the primary endpoint of the 3-point MACE, or major adverse cardiovascular events. So empagliflozin demonstrated cardiovascular superiority, but as a secondary analysis in that study, the panel on the left shows that there appeared to be a stabilization of the estimated glomerular filtration rate. 2 years later, when the Canvas study looking at canagliflozin published, this also, as a secondary endpoint, examined renal decline and appeared to show a stabilization. So a suggestion that these drugs not only had benefit in terms of the primary endpoint of the study, but also had some renal benefits. So this has been followed up by a trial specifically looking at primary renal endpoints, so as to be able to persuade not only clinicians, but also the regulators that this is a true effect. And the DAPA-CKD study examined such a primary outcome, a composite cardiorenal outcome of sustained reduction of more than 50% in eGFR, end-stage kidney disease, and renal or cardiovascular death. And on this Kaplan-Meier curve here, you can see that the two lines split very quickly and decisively in favor of fewer events for dapagliflozin. Indeed, the hazard ratio in this study was 0.61, so almost a 40% reduction in the endpoints. This was highly statistically significant, and the number needed to treat to prevent one of these endpoints was an amazingly low 19. Perhaps of even more interest, though, in this study, only 2/3 of the individuals had known type 2 diabetes, and the remainder were either normoglycemic or perhaps had impaired glucose tolerance. So this is an effect that's clearly independent of glucose lowering and led to the license for dapagliflozin as a protective agent against chronic kidney disease. Now, this follows on from a similar license being awarded to dapagliflozin and subsequently other SGLT2 inhibitors for protection against heart failure. Once again, this was a secondary endpoint in the original cardiovascular outcome trials, but followed up in this case by the DAPA-HF study that showed a 26% relative risk reduction for hospitalization for heart failure, urgent heart failure visits, or cardiovascular death, the composite endpoint. So hazard ratio of 0.74, and once again, a very, very low number needed to treat of only 21. So these additional benefits, both independent of glucose lowering, because in DAPA-HF, only 42% of the patients actually had known type 2 diabetes at initiation of the trial. These are clearly independent and have led to multiple licenses for dapagliflozin, and other SGLT2s will be following. So as a result of these studies, in 2021, myself and colleagues in the UK issued an update on a document named Clinical Practice Guidelines for Management of Hyperglycemia in Adults with Diabetic Kidney Disease. And in this, we suggested that all individuals with type 2 diabetes should be considered for the use of an SGLT2 inhibitor down to an eGFR of 30 mils per minute, and that this should be irrespective of glycemic control, so even those patients already hitting target with perhaps metformin or other drugs. And this is a document that is now available on the World Wide Web and has been published in Diabetic Medicine and the British Journal of Diabetes. Now on to the GLP-1 receptor agonists. This is the ADA-ESD consensus statement, which recommends GLP-1 receptor agonists in various areas of the glucose-lowering pathway. You can see at the top that metformin remains the first-line treatment, but thereafter, in terms of second-line therapy, those patients with atherosclerotic cardiovascular disease or heart failure or CKD, that's the panel on the left, should be considered for GLP-1 receptor agonists as either a second or third-line therapy. In those for whom hypoglycemia is a concern, GLP-1 receptor agonists should be considered because of the low risk of hypoglycemia with this class. Then in the third column here, for those patients for whom weight is a concern, then once again, GLP-1 receptor agonists are considered as a second-line therapy. However, there's no doubt that in the UK and globally, the use of GLP-1 receptor agonists is much lower than you would imagine from the widespread recommendation in guidelines. So quite why is that, and what sort of areas are being addressed by ongoing studies? Well, one of the questions is whether there is a benefit in terms of kidney disease outcomes. We've already seen that sodium glucose transporter 2 inhibitors, I believe, as a class effect, will reduce the progression of GFR, loss of GFR in patients with CKD. What about the GLP-1 receptor agonists? Well, these are data from the SUSTAIN-6 study, which looked at injectable subcutaneous semaglutide. And you can see that there was a reduction in the secondary endpoint of new or worsening nephropathy. But if you look at the panel on the right here, you can see that this was almost entirely down to a reduction in new or persistent macroalbuminuria. And I think that would be regarded as a surrogate endpoint rather than a hard endpoint, such as the reduction in doubling of serum creatinine or a fall off in the eGFR. So this is going to be examined. And the reason it's being examined is that there are suggestions from the trials that perhaps there is a GFR benefit seen with GLP-1 receptor agonists. This was a post-hoc analysis of the LEADER study, and here you can see panels looking at GFR decline in different baseline cohorts within the study. And if you look at the bottom left panel here, you can see that those patients with an eGFR baseline between 30 and 59 mils per minute appear to have a significant benefit from being on liraglutide. And I can tell you that subsequently analyses that have been done in both the SUSTAIN-6 and the PIONEER-6 studies suggest that semaglutide has a similar benefit in those patients with stage 3 chronic kidney disease. So this has led to a trial being designed known as FLOW. And FLOW is going to examine the population that you see in the KDIGO graph at the top right here, 3,160 patients with type 2 diabetes, HbA1c less than 10%, and an eGFR of 75 to less than 50, and a urinary albumin creatinine ratio of 305,000 milligrams per gram, or a lower GFR target with a slightly lower urinary albumin creatinine ratio starting point. And this is using the semaglutide 1.0 milligrams per week with CKD standard of care in people with type 2 diabetes versus a match volume placebo study. And this is going on at the moment and is expected to report in about 2 to 3 years. So we will know for certain whether there is a definitive hard endpoint impact of GLP-1 receptors agonists in people with CKD. What about diabetic retinopathy? Well, there was a surprising finding in the SUSTAIN-6 study, once again using injectable subcutaneous semaglutide, in which there was a increased hazard ratio for diabetic retinopathy complications. And if you look at the panel on the right, this was spread throughout the various complications that were assessed. Now, this was completely surprising, and many of us believe that this relates to rapid glucose lowering, which is achieved with semaglutide on a background of established diabetic retinal disease. And this is consistent with the findings in the DCCT study, the Diabetes Control and Complications Trial, and also the finding that's been well known in pregnancy for many, many years, that if patients try to improve glycemic control rapidly, then they can actually put their eyes at risk. But following a recommendation from the European regulatory authorities, there is a trial going on to establish whether semaglutide is indeed a safe drug to use in the setting of diabetic retinopathy. And this one is known as the FOCUS trial. You can see it's a 5-year randomized double-masked parallel group placebo-controlled trial, once again using the subcutaneous injectable semaglutide 0.5 to 1 milligram once weekly versus placebo and standard of care for diabetes. And these patients have all got some evidence of retinopathy at recruitment into the trial. And the key endpoint is a change in the number of ETDRS steps during the progression of the trial, with secondary endpoints that are investigating other retinal outcomes. So this is definitely focused on people with diabetic retinopathy, and again, will give a definitive outcome regarding safety. Now, much of what I've spoken about so far is using the injectable semaglutide, so subcutaneous semaglutide, but many of you will be aware that an oral formulation is now available. We have it in the UK. I believe it will be launched in Bahrain in the next 12 months or so. And this is a co-formulation with the semaglutide peptide with a molecule known as SNAC, that is sodium hydroxybenzoyl aminocaprylate. Now, SNAC is a so-called absorption enhancer. It has been used with other products such as vitamin B12, which would normally be given by injection. And what it does is it affects both the gastric pH, and it also enhances the permeability of the gastric lining. And so what we have is a situation where the SNAC is co-formulated with the semaglutide in a single tablet. This is taken first thing after a fast with a small amount of water, and then when the tablet is in the stomach, there is a local rising of pH, so it becomes less acidic, and so the peptide is less likely to be destroyed, and it enhances the transcellular permeability of the semaglutide. Now, even with this technology, only about 1% of the semaglutide in a tablet is absorbed, and so the dosing over a period of a week is 100 times that seen with the subcutaneous semaglutide. This means it's given on a daily basis, once per day. There is variable absorption, but over time, because the long half-life of the semaglutide, once in the circulation, is maintained, these differences balance out, and it gives an effective molecule. Now, oral semaglutide has to go through cardiovascular outcome studies as per all glucose-lowering therapies in diabetes, and this is the Kaplan-Meier curve from the Pioneer 6 study. You can see here that the lines diverge. The number of events in those patients receiving oral semaglutide were fewer, giving a hazard ratio of 0.79, so 21% reduction. This showed safety, but it did not show superiority. And that's often raised questions in people's minds. But I point out that this was a study that was performed very, very quickly in a modest number of people, just over 3,000. And the median exposure to trial drug was less than 16 months. So this was always planned as a non-inferiority safety trial with the view that there would be a superiority trial coming in the rear, and this is indeed the case with the SOUL trial. So the SOUL trial is now an oral semaglutide study. It's using the top dose of 14 milligrams once per day, along with standard of care, and is compared with placebo. There are more than 9,600 patients in the study with type 2 diabetes and established cardiovascular disease or chronic kidney disease with an HbA1c between 6.5 and 10%. And this study is powered for superiority and will go on until a sufficient number of events have been completed to show this. As per the situation with all modern cardiovascular outcome trials in diabetes, the primary endpoint is the 3-point MACE. MACE stands for Major Adverse Cardiovascular Events, and in this study, it's cardiovascular death, non-fatal MI, and non-fatal stroke. Amazingly, despite the COVID-19 pandemic, the trial has recruited on time. It was actually ahead of time before the pandemic began to strike, but caught up over the period of time. And so the study is now completely recruited. It's event-driven, as I mentioned, and so we don't know precisely when it will finish, but it's estimated to be in another 2 to 3 years' time. And we have the midpoint of that trial coming along in the next few months. Semaglutide has also been used as a weight-reducing agent and is now licensed for this in the United States. You can see the step 1 program here is looking at a dose of 2.4 milligrams of subcutaneous semaglutide. And you see the weight reductions versus comparator of between 8 and 15%. And so very significant weight reduction seen with semaglutide, and indeed the oral semaglutide will also be investigated and probably launched as a weight reducing drug going forwards. Interestingly, and indeed novel, the fact that it is going through a cardiovascular outcome trial as a weight-reducing drug. This is the 2.5 milligrams per week versus placebo in 17,500 people. And these are people who have got established cardiovascular disease but don't have diabetes based on an HbA1c less than 6.5%. And this is the first cardiovascular outcome trial in the setting of obesity that has been sufficiently powered to show a significant benefit. Other areas that are now the focus for GLP-1 receptor agonists. This is the Essence trial looking at semaglutide, once again in the 2.4 milligram subcutaneous weekly dose versus placebo in patients with evidence of liver disease. This is a histological trial that is going to try and tease out whether there is a benefit of semaglutide in terms of liver pathology, and to try and tease out how much that relates to the weight reduction that's seen with this drug. And perhaps most excitingly of all, this is a meta-analysis of some of the GLP-1 trials looking at placebo versus GLP-1 and time to onset of dementia. And you can see that the lines on this Kaplan-Meier curve split, with there being suggestion of benefit for the GLP-1 receptor agonists. And so Novo Nordisk have now initiated a late-stage trial of semaglutide to see if it can modify Alzheimer's disease. And indeed, in the SOUL trial, we're currently doing various psychometric testing to see if there's any evidence that patients receiving oral semaglutide in that study are benefiting from the point of view of brain function. I'd like to briefly go on to dual peptide. So tirzepatide, a dual GLP-1 receptor agonist, GIP, gastrointestinal peptide agonist. This is a 39 amino acid linear peptide. It's multifunctional and it binds to both the receptors, and it in fact has much more potency for the GIP than it does for the GLP-1 receptor. And it has a long half-life. So once again, this is going to be a weekly treatment, at least initially as a subcutaneous injection. Now, tirzepatide is going through a large clinical program known as SURPASS. And you can see as you pass from left to right here, it's going from people with monotherapy, so early in the stage of type 2 diabetes, and then SURPASS 2, SURPASS 3, and SURPASS 4 are comparisons with semaglutide and then various insulins. And then at the final passage there, we've got 5 and 6, which is comparison with quick-acting insulin, and also as add-on to insulin glargine. And under keeping or under supporting all of these is a SURPASS CVOT, which is a cardiovascular outcome trial that is ongoing versus dulaglutide or Trulicity. What sort of benefits does it get? Well, this is looking at those patients who achieve an HbA1c less than 7%. And you can see that for the doses of tirzepatide, this is an amazing proportion, hitting in the early 90s getting those levels of HbA1c. And note in SURPASS-2, this is a comparison with semaglutide, albeit at the 1 milligram dose. And I'm sure you'll be aware that the 2 milligram dose has now been licensed for glucose lowering. The big thing about this drug probably, though, is its weight loss. This is looking at the number of people who achieve a 15% weight loss over these studies that vary between 40 and 52 weeks. And you can see that that's up to 43% of patients achieving that. Once again, I point you to SURPASS-2, 40 weeks versus semaglutide at the 1 milligram dose, and a 40% versus 9% in the semaglutide group achieving that weight reduction. So exciting times with the dual receptor agonists. Finally, I'd just like to talk a little bit about insulins. We are currently one of the trial centres involved in 2 of the Onwards trials. And the Onwards trials are looking at the once weekly preparation of basal insulin known as icodec. Onwards 1 is a trial looking at patients with type 2 diabetes who are initiated onto that insulin and making a comparison with once daily basal insulin. And then Onwards 6 is taking people with type 1 diabetes who are already on a basal bolus regime and randomizing them either to continued basal insulin on a daily basis or once weekly. So these are trials that are now fully recruited, and we would anticipate they will begin to report later this year. Just of major interest, I guess, is that this is a once weekly formulation, and so patients are given 7 times the dose that they would normally given per day. So the formulation is a U700 units per mil, and the starting dose is 70 units per week, which is the equivalent of 10 units per day for a once daily insulin. And then the dosing steps are in steps of 10 units. So I suspect this is going to cause a lot of concern and consternation for our pharmacy colleagues who have been in the past very wary about very high concentration insulins and the risk of hypoglycemia. But because the way this insulin is manufactured, and once again, it's got a protracted mode of action because of binding to albumin and the like, it should be safe going forwards. But of course, this is what the clinical trials will establish. So I'd like to stop at that point. Thank you for your attention. I hope you agree there have been lots of interesting elements in diabetes last year, and I think this is a very fast-moving field, and I anticipate there'll be lots of interest in the years going forwards. Thank you once again.